Welcome to this explainer on dyslipidemia. If you're a medical trainee, well, you're in exactly the right place. We're going to cut through all the complexity and give you the high-yield, need-to-know essentials for evaluation and management, all based on the current guidelines. Okay, let's take a look at our roadmap. We're going to follow the logical flow of a clinical encounter. First, what are we even talking about? Then, who and how do we screen? We'll cover lifestyle changes, then dive deep into statins, and finally, touch on those special cases and what to do when statins aren't quite enough. So, first things first, what exactly is dyslipidemia? Let's define the problem and really get a handle on why managing lipids is so incredibly critical for our patients' health. At its very core, dyslipidemia is just an imbalance of fats, cholesterol and triglycerides, in the blood. But that simple definition hides a huge problem. This imbalance is a major driver of what we call ASCVD. That's the underlying plaque buildup that causes the vast majority of heart attacks and strokes. To really manage this, you've got to know the key players. Think of LDL cholesterol as public enemy number one. It's the most atherogenic, it's what drives that plaque, and it's our primary target for therapy. Triglycerides also contribute to risk, and when they get super high, they can cause a totally different problem, pancreatitis. And HDL? Well, we used to think of it as the good cholesterol, and while higher levels are protective, we've learned that trying to raise it with drugs, well, it just doesn't work to improve outcomes, so we don't target it.
Okay, so we know what we're looking for. Now let's get into the practical stuff, the clinical workup. How do we find the patients who need our help? Who, when, and how do we evaluate?
The U.S. Preventive Services Task Force, the USPSTF, makes this part pretty straightforward. They recommend universal lipid screening for all adults between the ages of 40 and 75. The whole idea is to catch that risk early, way before it ever turns into a clinical event.
So, you get the lipid panel back. Now what? This is the crucial question, right? It's where we move beyond just looking at a lab value and start thinking like a clinician.
The modern approach has really shifted away from just treating a specific LDL number. Instead, it's all about calculating a patient's total 10-year risk of having a heart attack or stroke using tools like the pooled cohort equations. It gives you a much bigger, more holistic picture.
That risk score then puts patients into one of these four buckets. And this framework is what guides the conversation with your patient about starting a statin. It's all about shared decision-making, especially when they get into that intermediate risk category or higher. Now, here's the number I want you to burn into your brain, 190. An LDL of 190 or higher is a total game changer. It's a huge red flag, often pointing to a genetic condition like familial hypercholesterolemia. And for these patients, you don't even need the risk calculator. You go straight to a high-intensity statin, period. All right, before we even think about a prescription pad, we have to talk about the true foundation of management. This is, without a doubt, the most important intervention for every single patient. And here it is, therapeutic lifestyle changes, or TLCs. This is the absolute, non-negotiable bedrock of preventing cardiovascular disease. Every single patient at risk deserves to have this conversation.
These are the four pillars where patients can really take charge. We're talking about diet. Things like the DASH or Mediterranean diets were great. We're talking about getting active, aiming for that 150-minute-a-week goal. Managing weight, where even a small percentage makes a big difference. And of course, quitting smoking, which is just absolutely critical. These aren't just suggestions. This is powerful medicine.
Okay, so lifestyle is established. Now we can talk about the mainstay of our medical therapy, statins. Let's get into how we use these incredibly powerful tools effectively and, just as importantly, safely.
If you're a trainee, this is a table to memorize. The guidelines today are all about picking the right intensity, high or moderate, based on the patient's risk profile from the get-go. This is a big shift from the old way of just starting low and slowly titrating up to some target number. We pick the right tool for the job right from the beginning.
So this is probably the number one question you're going to get in clinic. Patients hear things, they read things online about statin side effects, and they're worried. It is absolutely crucial that we can talk to them using the real data.
And the good news is, the evidence from the big randomized controlled trials is incredibly reassuring. Yes, side effects can happen, but the rates of serious ones are really, really low. Muscle symptoms, barely more common than in the placebo groups. Serious liver injury, extremely rare. For the overwhelming majority of patients, the benefits in preventing heart attacks and strokes just massively outweigh these small risks.
And let's be clear about this first follow-up lab check. Its purpose is not to chase some perfect LDL number. It's a simple check for two things. 1. Is the patient actually taking the medication? And 2. Is it working as expected? For a high-intensity statin, we expect to see that LDL drop by at least 50%.
Finally, let's get into some of the more complex scenarios, the clinical nuances that you are absolutely going to encounter in practice. This is where we go beyond the standard statin playbook.
This is the next level of management. For secondary prevention, that's in patients who've already had an event, we get really aggressive with high-intensity statins. If that's not enough, we add on other drugs like ezetimibe or the powerful PCSK9 inhibitors. And then there's severe hypertriglyceridemia. When triglycerides are over 500, the immediate goal actually flips to preventing pancreatitis, which often means using fibrates.
And hey, don't forget to use your eyes. Sometimes the biggest clues are staring you right in the face during the physical exam. If you see these little yellowish lipid deposits around the eyelids, they're called xanthelasma, that should be an immediate trigger to check a lipid panel. Especially in a younger patient, it can be a huge clue to a serious underlying genetic condition.
Here's a critical pearl for every trainee. Before you stamp a patient with a diagnosis of primary dyslipidemia, you have to stop and think about secondary causes. Could something else be driving those high lipids? Things like an underactive thyroid, nephrotic syndrome, or even medications like glucocorticoids. Always rule those out first.
And that leaves us with a really interesting question for the future. With these incredibly powerful new drugs, we can now drive LDL cholesterol down to levels that were once unimaginable. So, how low do we go? Is there such a thing as too low? The final chapter on lipid management is definitely still being written.